This is an approach to pulmonary hypertension. It mirrors the WHO and Harrison's, but makes it a lot clearer. I want to start off by talking about how a cardiologist views pulmonary hypertension, and then go into the method about the causes and the workup for pulmonary hypertension. So a cardiologist is going to see an echo, and it's going to have an estimated pulmonary artery pressure that's elevated. Some stuff's going to happen, and then that cardiologist will do a right heart cath to confirm pulmonary hypertension with a vasodilator challenge. If there is vasodilation, that person wins, yay. They can be treated with calcium channel blockers and do well. That happens in about 5% of cases. What usually happens instead is nothing, boo, and this person is relegated to experimental treatments. Usually these are continuous infusion medications like bosentan, alprostadil, and other prostaglandin analogs, and what sildenafil was originally made for, Revatio. Right? That's not really what you're going to be involved in, because the cardiologist is going to do this. Right? And you are going to be everything in between. And yes, there is a WHO classification, groups 1 through 5, and I'll keep you appraised of how you refer to these along with my method. And Harrison's has a really convoluted algorithm, which is just not necessary. So what I've done is I've shortened it up and used an image you're likely to be familiar with, having used this course before. So the way I see the heart and lungs, you've got a right heart, and you got a left heart, and in between, you got lungs. And the pulmonary artery brings blood from the right heart to the lungs, and the pulmonary vein from the lungs to the left heart. My algorithm is start on the right, go to the left. First thing you see is the left ventricle. If the left ventricle breaks, fluid is going to back up into the pulmonary vein. If the pulmonary vein will then have hydrostatic pressure, which will be translated back onto the capillaries, which will be further translated back onto the pulmonary artery. This is group 2, pulmonary venous, caused by cardiac dysfunction. Thanks. What you meant was CHF can lead to pulmonary hypertension. How do you look for CHF? You get an echo. Now the CHF obviously has to be left-sided, but it doesn't matter if it's diastolic or systolic. The next group has to do with pulmonary, that is intraparenchymal. And there's 2 ways that you can get that. You can either have a big puffy lung from obstructive lung disease, which means COPD, or you can have a scarred down lung, restrictive diseases, interstitial lung disease, now called diffuse parenchymal lung disease, DPLD. In both cases of intraparenchymal lung disease, what happens is hypoxia. At the alveolus, unlike everywhere else in the body, if there is low oxygen, the capillaries and the arterioles connected to them vasoconstrict in an attempt to shunt blood away to another alveolus that has better oxygen. In these diseases, the entire lung has low oxygen, so all of the arterioles vasoconstrict. If you vasoconstrict all the pathways, all you do is increase the resistance, thereby increasing the resistance in the pulmonary artery, causing pulmonary artery hypertension. It's the hypoxemia that does it. My method takes it from the right to the left. Start with the echo, easy to do, confirm the EPAP's elevated. Then the next one up is more common in DPLD, And while a chest x-ray isn't a bad place to start, it's not useful. If you already know they have pulmonary hypertension, chest x-ray is not going to cut it. So confirm they haven't obstructive lung disease or rule it out with pulmonary function tests. You notice the echo and PFTs are cheap and non-invasive. Once you start getting further over to the left is where you start getting more expensive, radiation exposure, and invasive. To assess DPLD, you need a high-res CT. We'll talk about the difference between high-res and CT scan at the end. The other way you can get this scarred down looking lung is with obstructive sleep apnea. And we're going to see more of this as obesity rates increase. Evaluate obstructive sleep apnea with a sleep study. Group 4 is pulmonary arterial, caused by clots. Group 5, by the way, is other. Thanks, WHO. If you have a clot in the pulmonary artery, that's like vasoconstriction everywhere because now you've got less ways of getting blood through. This is not acute. Acute thromboembolism, that's big, that causes increase in pulmonary resistance, can cause acute RV failure, and that causes death. This is non-acute PE. This is chronic thromboembolic pulmonary hypertension. Chronic thromboembolic, which is assessed by an angiogram or a VQ scan. Once you've done the echo, PFDs, high-res sleep study, and ruled out chronic thromboembolic pulmonary hypertension, and they still have pulmonary hypertension, now you're at group 1, primary pulmonary hypertension. At this point, you still have workup to do. This is more looking for rheumatologic stuff and more shotgunny than it is an approach, but you only do this if they obviously have symptoms of that in another way. But if you've gotten here through this process, now you should get the rheumatologic panel, ANA, rheumatoid factor, SSA, and SSB, and other viral stuff that causes systemic problems. HIV, Hep panel, but looking really for hepatitis C and a TSH. Okay, so all the stuff in between a cardiologist from the echo to the right heart cath is you. And you can figure out how to work out the problem starting on the right of the board and working left. The reason why we do this is because the pulmonary artery is a low pressure system, right? And it doesn't have a very big muscular wall. But if you increase pulmonary resistance, you make the heart squeeze harder, you're going to cause this arterial, the arteries, to get stronger to resist the increase in force that's required to get the blood through. What that's going to do, in order to get stronger, they're going to build their muscles. You cause a compromise of the lumen. And once there's all this muscle, you can't undo it. Right? So what you want to do is prevent this process from happening in the first place because you can't go back. All you're going to do with these treatments is try to get this really stiff tube to open a little bit and to prevent getting any beefier. And the problem is that it doesn't get beefier on the way out, it gets only beefier in towards the middle. And then we'll close with the difference between high-res and regular CTs. This is a lung, this is supposed to be the same lung. They both have a big old mass right here. And then there is the interstitium in between the cells. Really want to get in. And it's not big, it's very small, it's hyper detailed. If you remember from microbiology, if you wanted to get a really good section of something, you wanted to make it really thin. In pathology labs, to look at tissue, you wanted just one cell thick. If you don't care about visual quality, but you don't want to miss anything, just take a big old chunk. That's the difference between high-res and regular. High-res takes slices that are super thin, and they very well miss something huge. But the goal is to keep them so thin that the resolution is really high, so you get a good look at the interstitium. High-res interstitium. Normal CTs don't want to miss anything. So they take big hunkin' chunks. Now you might say, why don't you just take more slices with the high res? You could, but that would take more time, more power, more computing time. And so you want to pick your study. If you're looking for masses and clots, pneumonias, regular CT. If you're looking for interstitial lung disease, high res. And really the high res CT is only used in DPLD. That's my approach to pulmonary hypertension.